Welcome to our live webinar titled Moderate Aplastic Anemia, a Treatment Dilemma. Thank you for joining us. My name is Lee Clark, patient educator, and I will be moderating the presentation today. As we get started, I would like to recognize the generosity of our corporate sponsors and the generous support of patients, families, and caregivers for supporting our webinar programs. Due to the high volume of teleconferences on the internet, it is possible you may lose your connection during the webinar. If you are unable to view the webinar online, you can call in to hear the audio portion of the program using the call-in number in your reminder email. Today's program will be archived to our website within 2 to 3 business days. You will be notified when it is live and ready for viewing. Immediately following the presentation, there will be a question and answer session. Please feel free to submit questions at any time during the presentation. To submit a question or a comment, open the Q&A window in the lower part of the screen. Type in the question in the small text box window, and when you have finished typing your question, just hit enter. We will do our best to get to all questions today. When asking questions, I do ask that you do 2 things to help me manage the incoming questions. First, submit your entire question all at the same time. Second, please do not share private health information in your question. Our speaker cannot answer any specific questions related to your health care. Today's specialist is Swapna Thota. Dr. Thota is an Assistant Professor of Oncology at Roswell Park Comprehensive Cancer Center and an Associate Professor of Medicine at Jacobs School of Medicine and Biomedical Sciences at State University of New York at Buffalo. She specializes in acute leukemia, myeloproliferative neoplasms, myelodysplastic syndrome, aplastic anemia, and PNH, and acquired bone marrow failure conditions. She is a member of the American Society of Hematology, American Society of Clinical Oncology, and American College of Physicians. With that said, it is my pleasure to welcome Dr. Thota.
Good afternoon, everybody. Thanks for joining this webinar on management of moderate aplastic anemia and the treatment dilemmas. It is my pleasure. I would like to thank AMDS Foundation for this invitation to be talking with you all today. I'm an assistant professor here at Roswell Park Comprehensive Cancer Center in Buffalo, New York, and I have a very specific interest in acquired bone marrow failure conditions and specific aplastic anemia. I take extreme pleasure in treating my patients who have this rare disorder, to provide them a home for a rare blood condition and to feel them comforted in taking care of them with the required specialized care. With that introduction, I would like to delve into today's topic of managing moderate aplastic anemia. I always like to tell stories of patients that I took care of, so the major take-home points are struck with you and you learn the most important lessons of the day. I would like to give some historical significance as to where this all started with. So aplastic anemia was actually not defined by a hematologist, but by a pathologist, Dr. Paul Ehrlich, who in 1888 was really struck by the death of a young woman who passed from having a high fever, anemia, and bleeding. So he did an examination of her bone marrow and found that all the cells in the bone marrow had disappeared and were replaced with fat, and found an empty bone marrow and called it aplastic, which means an empty bone marrow based on a Greek word, which eventually became aplastic anemia. As you note in this picture, a very cellular marrow is replaced by an empty bone marrow. Moving on to the next slide. We have 3 patients that I was honored to take care of over the past few years that I want to tell you what has happened to these patients, and that each person, although have the common diagnosis, had a very different journey and how they are doing today. The first case is a 21-year-old female presenting with menorrhagia diagnosed with moderate aplastic anemia. The second patient is a 53-year-old male that I take care of who presented with fatigue and found to have pancytopenia with a 30% cellular marrow. The third patient is a 65-year-old male with thrombocytopenia, a variably cellular marrow, has taken visits to several physicians before he established with us here at Roswell, and was continuing to be treated as ITP without any response. Next slide, please. So moderate aplastic anemia is a challenging clinical condition because the course of moderate aplastic anemia could be really fulminant, being severely sick from low blood counts, or could be an indolent course where they are noted to have low blood counts but were asymptomatic. So there's a full spectrum. And aplastic anemia, moderate aplastic anemia in specific, has overlapping features with other clinical conditions such as paroxysmal nocturnal hemoglobinuria, hypoplastic MDS, some inherited conditions such as Fanconi anemia, and other acquired bone marrow conditions such as LGL, short form for large granulous lymphocytic leukemia. So because of all these conditions that can look similar on a bone marrow biopsy, there is some diagnostic challenge associated with moderate aplastic anemia. To identify these different conditions and to appropriately diagnose the patients with the correct diagnosis is key to the management of aplastic anemia. Next slide, please. So I want to spend some time in differentiating how your physician could differentiate whether you have moderate aplastic anemia or if it is a presentation of hypocellular MDS. These patients can really, although there are overlapping features, some specific features could differentiate one from the other because this remains the biggest differential diagnosis for your low blood counts. If you do have hypocellular MDS, it typically happens in an elderly patient, usually presenting in the ages of 70s. Aplastic anemia being an immune disorder as opposed to a cancerous condition, which is MDS, has a bimodal distribution of age. So it is commonly present in young, and the second peak in the age of 60-year-olds on an average. Dysplasia is frequently present in myelodysplasia, but is rare in an aplastic anemia condition. It really takes a specialized pathologist to read this dysplasia in a hypocellular marrow where there are very few cells to read. Cytogenetics, which is an alternate term for looking at the chromosomes inside the cells in the bone marrow, are frequently abnormal, about 50% of the times in hypocellular MDS, and are usually normal in an aplastic anemia patient. PNH, which is short form for paroxysmal nocturnal hemoglobinuria, is quite rare in MDS patients and is frequently associated with aplastic anemia about 30% of the time. When you take a deeper dive into the DNA and the molecular events and the mutations that can happen, these are genetic mistakes that frequently tend to happen in splicing genes and RAS genes, which are present in MDS, but are not frequent in aplastic anemia. When there are mutations, they're present in very small clones and are frequently present in genes such as B-core and B-core L1. Clonal evolution, that means the chance of second mistake happening and the disease changing to a more aggressive form, is very common in hypocellular MDS, but is rather rare and is restricted to about 10% of the patients in aplastic anemia in the historical cohorts. Blasts, which are cancerous cells, are absent in aplastic anemia and are increased in hypocellular MDS. Macrocytosis on a peripheral blood smear is frequently present in myelodysplasia, while it can be present in aplastic anemia when associated with a PNH presentation as well. With that, next slide. It is very important to pay attention. All moderate aplastic anemia is not the same. There are different things, as I had mentioned, that could look alike. So one has to pay attention to the age and the onset of cytopenias and look for syndromic features, whether this person was born with a gene that could have given him aplastic anemia, which we define as inherited conditions, And there are certain medical terms such as Fanconi anemia, Shwachman-Diamond syndrome, dyskeratosis congenita, where you can find like early graying of hair, pancreatic insufficiency, and other features that go along with the bone marrow failure that raises the suspicion of a physician whether you are dealing with an inherited condition or an acquired condition. In an acquired aplastic anemia, usually we do not know the reason why the patient developed aplastic anemia, what we call as primary or idiopathic. Sometimes we do recognize with the history taking that there was a prodrome of viral illness. There was medication such as chloramphenicol, which is classically described, or sulfur drugs or gold salts or other drugs that could have induced a drug-induced acquired aplastic anemia. Autoimmune conditions could give rise to acquired aplastic anemia. Radiation, such as seen in Japan with Nagasaki, Hiroshima, where several patients have developed radiation-induced aplastic anemia. Graft versus host disease in bone marrow transplant patients is another situation where you can see an acquired aplastic anemia, and in rare situations, pregnant women suffer from acquired aplastic anemia. Each of these conditions, although present with low blood counts or similar in presentation, come with a different prognostic value and response to immunosuppression. For an example, a condition such as drug-induced aplastic anemia has very different course than an acquired idiopathic aplastic anemia and is frequently non-responsive to immunosuppression. So the trajectory of these patients is very different than other acquired aplastic anemia. So it is very important for the physician to determine if there is any association for these known causes of aplastic anemia. Next slide, please. So when your physician is talking with you for the first time, it is very important to take your time and to get a detailed history and physical, the things that I had mentioned before: drug exposure, viral illness, suspicion of a genetic disorder if multiple members of the family, age of a patient, early graying, or the height of a patient, or another organ failure raises the suspicion for an inherited cause. A review of records from before, looking at the blood counts, reticulocyte count could give them a vision of how long it has taken, whether these are acute onset of cytopenias, or has this been a chronic illness that has been going on and rather presenting as an indolent illness. It is very important to make sure that the condition, the reversible causes of low blood counts, such as nutritional causes, viral illness, EBV, CMV, other immune disorders, are ruled out before somebody is given a diagnosis of aplastic anemia. Bone marrow biopsy to exclude other cancerous conditions of the bone marrow, such as MDS or myeloproliferative neoplasms, is very important to give aplastic anemia diagnosis, as it is a diagnosis of exclusion and there is no specific diagnostic test. One has to pay attention to cytogenetics obtained from the bone marrow biopsy, and when feasible, a next generation sequencing panel, if available, could provide additional diagnostic information for the physicians treating your condition. PNH flow is a standardized test that we perform with a patient when we are suspicious of aplastic anemia. Next slide, please. Once we have diagnosed, we have done a detailed history and physical of a patient, and we know we have acquired aplastic anemia. We categorize patients based on their blood counts, whether they have very severe aplastic anemia, severe aplastic anemia, or moderate aplastic anemia. Moderate aplastic anemia is defined by blood counts that do not fit the criteria for very severe and severe. These are called the Comita criteria based on a historical paper. Cellularity is typically less than 25%. Your absolute neutrophil count, which is your immune system level, should be greater than 500 per microliter. Your reticulocyte count is depressed, and your platelets are typically greater than 20%. Most patients with moderate aplastic anemia are independent of hematological transfusions or blood transfusions, but on a rare occasion, there are patients who do require blood transfusions. Once we classify the patients, next slide, please. I want to describe a little bit about one of the patients, the third case in specific, the 65-year-old man who has been treated as immune thrombocytopenia, who has come to me for an evaluation of what is it that's causing him to have low platelets. When I reviewed his bone marrow biopsy, he has had 2 bone marrow biopsies over a time span of 3 months to identify the cause. And the first specimen was an inadequate specimen, and the second specimen showed a variably cellular bone marrow. The patient was treated as ITP, was given steroids and immunoglobulins with his counts, in fact, worsening and not getting better. The point I'm trying to drive with this case is a qualitative and quantitative assessment of biopsy is key to establish aplastic anemia diagnosis. It has to be a 1 centimeter long biopsy, which is considered as an adequate and an optimal specimen to be submitted for the pathologist for a good review of the cellularity, because cellularity of the aspirate and biopsy obtained from a bone marrow biopsy are key to diagnose patients with aplastic anemia. Because of a lack of adequate specimen early on in his disease course, it took this gentleman a few months before they had realized that something more than a usual condition to cause low platelets has happened to him, and prompting a referral to a specialized care institution. We did obtain PNH flow on him and had identified a very small clone of PNH being present concomitantly with this occasional pockets of hypoplasia in his marrow. And then we were able to diagnose him with moderate aplastic anemia and led to subsequent treatment initiation. Over the next few slides, I'm going to show you how this gentleman's treatment has proceeded and how he has responded to treatment. Moderate aplastic anemia is a diagnostic challenge because cellularity obtained from bone marrow biopsy is the only number that is going to point you towards the actual diagnosis of moderate aplastic anemia. If you have a 60-year-old man presenting with a 30% cellular marrow, which is expected to be 40%, the 10% decrease might point you towards, and lack of other explanations may point you towards moderate aplastic anemia diagnosis, because it takes an expert pathologist to identify this change in cellularities. It is important that the biopsies that you are being put through are reviewed by a specialized pathologist to diagnose you with moderate aplastic anemia as your confirmed diagnosis. Bone marrow biopsy sampling errors are unfortunately quite frequent, and serially obtained biopsies can change in appearance, and you have to be cognizant of discrepancies between different bone marrow biopsies. It is an inherent thing for this procedure. Next slide, please. I think a lot of burning questions for many patients is what happens when I am diagnosed with moderate aplastic anemia. It's an immune disorder. What does it look like when you're newly diagnosed? It's scary for many people. So when I meet with people, we typically talk about that moderate aplastic, once you're diagnosed with aplastic anemia, and I think you have moderate aplastic anemia, the usual thing I tell patients is in 1/3 of these patients, it's an indolent disease where your blood counts are not too low for me to intervene. You're rather asymptomatic because of where your blood counts are, and we can just wait and watch and see how your blood counts tend to behave over time. For 1/3 of the patients, they tend to remain stable with just me being an emotional support and helping them through the diagnosis and the symptoms they are facing. And in 1/3 of the patients, this condition of moderate aplastic anemia could progress to severe aplastic anemia. And in some cases, although the cytopenias are mild because of occasional transfusion requirement, they do need intervention with immunosuppressive therapy. And there is a risk of AML and MDS transformation to a lesser extent than severe aplastic anemia, but it is inherent to moderate aplastic anemia as well. Next slide, please. This is a study that colleagues at Cleveland Clinic and myself have worked and taken care of over the past many years. It's the story of 85 patients. Each line in this bar plot is an individual patient and how long we have taken care of them. And it shows you that many people, all the blue lines, who have been diagnosed with moderate aplastic anemia just remain moderate aplastic anemia. About 76% of the patients tended to have a chronicity of their low blood counts without any further worsening, occasionally needing treatment, but their condition did not change to any other diagnosis. In 13% of the people in this 86 patient cohort progressed to severe aplastic anemia. 10% of the patients developed PNH, and 1% developed acute myeloid leukemia. Next slide, please. So just to go over moderate aplastic anemia, so what is the dilemma? There's a dilemma in diagnosis because it takes a good bone marrow biopsy and a good pathologist and a good hematologist to give you this diagnosis. Once you have this diagnosis, there is no standardized approach as to X treatment applies for everybody. Really, we look at age at the diagnosis, each individual as an independent person, and see what is the blood count that is giving them, what is the degree of your cytopenias, and do you have a bone marrow transplant donor? What is your risk of transforming to other diagnoses such as severe aplastic anemia or MDS, and then provide a tailored approach to each individual case. And to provide the best supportive care is key to managing moderate aplastic anemia. So when I come across moderate aplastic anemia, there are certain general rules that we can follow. As I had mentioned, in the majority of people, as I've shown in the previous slide, this remains a distinct chronic condition which doesn't worsen, and where your blood counts, you may be transfusion independent, you may not be experiencing any infection or bleeding. Where we think you have adequate counts, we can just wait and watch your counts and support you with other supportive treatment. So observation is applicable for a majority of patients whose blood counts are adequate for them to carry on with the routine life. When the patient becomes transfusion dependent, or when they present to me with very low counts that are not reaching the diagnosis of severe or very severe aplastic anemia, depending on the comorbidities of the patient, depending on what else is happening with them, can I take them through an intensive immunosuppression, or do I think just cyclosporin alone, monotherapy, will be in their benefit? I take into all the comorbidities and their blood counts into account and either suggest a combination immunosuppression with anti-thymocyte globulin from either horse, ATG for short form, or rabbit. Horse is the preferred first-line agent, along with the combination of cyclosporin. Or I could start them with cyclosporin alone, wait for 3 months for a response, and if there is no response or if the counts are further worsening, we can add on ATG on top as a second line of therapy. Eltrombopag and androgens are the other effective agents that can be used in alone or in combination with immunosuppressive therapy. This is a general approach for most moderate aplastic anemia patients, but like I said in the beginning, I individualize the care for each individual patient. If somebody has renal dysfunction, has like nerve disorder that cannot take cyclosporin, there are occasions where I choose Eltrombopag as their first-line treatment of choice as opposed to immunosuppressive approach. So really the care is individualized, and unfortunately, although we have an effective agents, there is no standardized approach for every patient. It has to be case specific. Next slide, please. So transplant, in my younger patients who are diagnosed less than age 21, who are diagnosed with who are diagnosed with moderate aplastic anemia, who have a sibling donor, as you see in these curves here, the blue line is an HLA identical sibling donor. And among these patients, you see about 1,300 patients here. that have undergone with the diagnosis of aplastic anemia, a bone marrow transplantation. I prefer this for my younger patients. Over time period after the initial toxicity of bone marrow transplant, they really tend to live a normal life over as the years pass. The risk of transplant with GVHD and other outcomes that come of a bone marrow transplant is higher with unrelated donors. So on a case-by-case basis and depending on the availability of a well-suitable donor, bone marrow transplantation is advisable for a moderate aplastic anemia patient. Next slide. Talking about anti-thymocyte globulin or ATG, this is serum obtained from horse or rabbit. It is an effective treatment for moderate aplastic anemia. There are two prospective trials. I presented to you the most historical trial published in 1983 from the NHLBI that showed that has enrolled 42 patients at that time in 1983, ATG was a novel drug, and they have chosen to randomize patients to either get ATG, so half of them got ATG and half of them were in control group. And among these patients who were randomized to ATG treatment, they were both severe aplastic anemia as well as moderate aplastic anemia cases. There was a 50% response. This response that I quote is applicable for 1983. The responses are higher than that in the modern age, which we will get to over the next few slides. But this shows that the ATG is an effective treatment and is a standard of care for severe aplastic anemia patients, and it is also recommended for moderate aplastic anemia patient and is equally efficacious. Really, the degree of cytopenias do not matter for who responds and does not respond to ATG. A key finding in this study is duration of aplasia. So if somebody has taken multiple visits to other hematologists before they ended up being diagnosed with aplastic anemia or got the appropriate treatment, this time to get the treatment, the duration of aplastic anemia is inversely correlating with the response. So the longer you take to get the appropriate treatment, the lesser the chance of success. So getting to a specialized care place is extremely important for patients with aplastic anemia. Next slide, please. The other effective agent over the past few years has been Eltrombopag. It's a thrombopoietin stimulant. So it is an agent, it's a stem cell booster. It is FDA approved for severe aplastic anemia patients in combination with immunosuppressive therapy. It is an effective agent for moderate aplastic anemia. Colleagues at NHLBI again have studied about 36 patients who in a phase 2 trial prospectively for patients who have not responded to previous immunosuppressive therapy with monotherapy of Eltrombopag. They have dose escalated it from 50 milligrams to 150 milligrams over time and identified that 50% of this cohort with moderate aplastic anemia who have been relapsed or refractory to primary line of therapy, which tends to be immunosuppressive therapy, have responded to Eltrombopag. And as you see in the bottom bar plots here, both erythroid endpoints and B cell lineage and platelets, not just so, although it's a platelet booster, in aplastic anemia, Eltrombopag actually leads to all 3 cell lines improvement, as you have noted here. Even people who have received prior immunosuppressive therapy tend to respond. Although you fail the initial therapy, you continue to respond to a stem cell booster agent such as Eltrombopag. This is a game changer for a lot of aplastic anemia patients and is an incredible improvement over the past few years to the armamentarium that physicians have to help our moderate and severe aplastic anemia patients. Next slide, please. So treatment patterns. I have shown you the story of the 85 patients we have treated previously in our cohort. And here is the different kinds of treatment. This is a pie chart here where you see in the first line of treatment among the people, you see about half the cohort, we did not have to ever treat these patients. And in the remainder who needed treatment, about 69% we have initiated cyclosporin monotherapy, one or tacrolimus. 5% it was ATG in combination with cyclosporin. Bone marrow transplant for 3% of our patients. Just androgens alone in some patients, and Eltrombopag as their first line of treatment. So the cases were chosen based on their cytopenias, their comorbidities, and other conditions they have, and the treatments can vary from ATG to any form of immunosuppression, either in combination or used alone, Eltrombopag, androgen, all the way to bone marrow transplantation. Those patients who needed a second line of therapy, you see a whole array of different kinds of agents being used in second line of therapy and experiencing good responses, both partial or complete. The number of patients who have not responded, about 1/3 of the patients to their first line treatment moved on to their second line treatment, and you see a majority of them tend to have either a complete response or a partial response. A minority who have moderate aplastic anemia tend to remain refractory to our first and second line treatment. So treatment has to be really individualized based on each patient's specific needs. The younger patients get bone marrow transplantations. A majority of people can be observed. Immunosuppression could be used alone or in combination with Eltrombopag, androgens, alemtuzumab, an alternative form of immunosuppressive therapy, remain as a very good salvage agents for patients with moderate aplastic anemia. Next slide, please. This is the biggest concern for a majority of patients with aplastic anemia. You have been told you have an immune disorder, but you also were probably heard that there is a chance of this condition getting worse and perhaps changing to something more aggressive, such as acute myeloid leukemia. So in the cohort and in other historical cohorts as well, we have compared the outcomes in terms of how long people live, how long does it take for people to progress. And the blue line here, which is on top of the severe aplastic anemia, shows you that patients with a distinct entity of moderate aplastic anemia tend to live longer and do better than patients with severe aplastic anemia. Overall, although the curves are different for them, both severe and aplastic anemia are very well managed conditions, and most patients tend to do good. Moderate patients tend to fare better than severe aplastic anemia patients. In terms of progressing to PNH, there is no difference. There's no difference between moderate and severe aplastic anemia patients. Next slide, please. I will want to close this presentation going back to the 3 cases and how the journeys were different for all these 3 different patients based on their each individual case details. So the very first patient that we talked about was a 21-year-old female that presented to us with menorrhagia, present to a gynecologist who noted extreme cytopenias, and sent to our institution directly, where we did a bone marrow biopsy, noted a significantly hypocellular bone marrow, and diagnosed her with moderate aplastic anemia. There was no dysplasia in her bone marrow. There are no other features of Fanconi anemias. We have sent out tests for genetic screening. There's no other family history. She's the only person who's ever been diagnosed with the blood disorder. Her DNA was normal, called normal karyotype, and there was a small PNH clone present in this patient. Because of her age of diagnosis, we made sure there was no other inherited cause that led her to have this diagnosis. We ensured that she had an acquired condition, and condition we do not know, there was no prodromal, viral, or other nutritional or immune causes. She was fortunate to have an identical twin sister who is her donor, and she is currently being teed up, awaiting for transplant, and remains on cyclosporin monotherapy with stable blood counts and remains as a moderate aplastic anemia awaiting her transplant to date. Because of her young age, a diagnosis and lifetime risk of leukemia being higher than the other aplastic anemia patients, bone marrow transplantation was the appropriate approach for this particular case. Case 2. Next slide, please. Is a 53-year-old man that I've met a few years ago who presented with fatigue to an outside physician who was found to have pancytopenia. He was immediately referred to me, and we did a bone marrow biopsy to identify there was a mild decrease, not reaching to less than 25% is the standard that where people tend to call it hypocellular, but he'd come to his, at 50 years of age, you're expected to have the cellularity is 100 minus your age, so he's expected to have 47% cellularity, where his cellularity had been decreased to 30% with absolutely no dysplasia or no other finding. He had a normal karyotype and also had a very small PNH clone at the time of diagnosis. Because his blood, he was transfusion independent, but over a period of time that I had watched him, his platelets have continued to downtrend. Recognizing this downtrend, I have initiated cyclosporin monotherapy within 3 months of him being diagnosed with aplastic anemia, which resulted in normalization of his blood count 6 months from his onset of illness, and immunosuppression was tapered down without any recurrence at a 1-year follow-up. I do surveillance bone marrows on them at an yearly time period just to ensure no further clonal progression is happening to this patient, and PNH clone, which is present at diagnosis, continues to be monitored, although he remains in complete response. It is critical because over time, some of the clones could evolve or disappear in these patients, to keep an eye on, as other immune disorders, aplastic anemia remains in remission for years and could relapse years later. So to continue to follow with your hematologist is absolutely essential for aplastic anemia patients. Case 3, please. So the third case was the gentleman we talked about early on, where there was a lot of diagnostic dilemma because he did not present with a hypocellular bone marrow, but with a variably cellular bone marrow. There is normal cellularity at places and pockets of hypoplasia. Although it took us a few months from when he started with the illness to diagnosis, after recognizing that he has progressively worsened thrombocytopenia at the time of presentation to our institution, we have initiated cyclosporin at the get-go. Because of the duration of cytopenias that occurred, the damage to his bone marrow, even after initiation of cyclosporin, his counts continued to downturn, so especially his platelet count. So we went ahead and added Eltrombopag to his treatment, waited for 3 months, and due to lack of efficacy at that time, we have put him on ATG plus cyclosporin for Eltrombopag, which has resulted in transfusion independence, improvement of counts a year from his diagnosis. To date, he remains transfusion independent and remains on Eltrombopag and very small doses of cyclosporin given his renal function to maintain transfusion independence. We have tried several times to taper his immunosuppression. His counts are really dependent on small amounts of continued immunosuppression years after his diagnosis. He is currently transfusion independent and living a normal life. Finally, next slide, please. No presentation in this time and era are complete without a comment about COVID-19 and aplastic anemia. Most aplastic anemia patients, because of their lower blood counts, are susceptible to complications from COVID-19. So I suggest to make sure that you continue to visit your doctors, get your blood count checked, and continue your surveillance if you're being observed. If you're on immunosuppression, it is key to continue most of your medications. I would suggest to avoid indoor meetings, and when they are necessary, please do wear your mask. And get your supplies if possible. If you're on stable doses of medications, get a 3-month supply, which decreases your visits to your physicians and to other high traffic areas such as medical supplies. Space out your transfusions if you're able to tolerate lower amounts of hemoglobin and hematocrit values. Next slide, please. With that, I would conclude and impress on the main points of today's presentation that moderate aplastic anemia can be a distinct clinical condition and could remain chronic in a majority of people without progressing to other myeloid disorders or bone marrow failure disorders. To recognize that an optimal diagnostic workup is key, and it is the challenging part to make a diagnosis of moderate aplastic anemia. Patient treatments are effective for your condition, and they're not standardized. They have to be individualized to each patient as we meet them. If possible, if there is a clinical trial available, because this is a rare condition, do your best when you're able to enroll onto a clinical trial in your local institution. With that, I would like to thank everybody who is here with me today. Next slide, please. It is a particularly difficult time for most of us going through a pandemic, an experience none of us had. Being ill during this process intensifies health issues and the emotional aspect of it. We all need to be inspired by other patients, the patients that I take care of. We all need to trust in each other and be hopeful. These are the mottos that keep me going. I'm very thankful to my patients for being my teachers and for giving me inspiration each day to show up for them and to help them and to learn from them. I'm thankful for my team at Leukemia to providing excellent care for patients with bone marrow failure, and to my mentors who taught me how to take care of these patients and the mentees that I'm passing it on to. My research is funded with the local alliance fund called Dr. Wyskowski's Fund. University of Buffalo's KL2 mentored career development program and Roswell Park Comprehensive Cancer Center's funding program. And I would like to thank Aplastic Anemia and MDS Foundation for providing excellent resources for the patients and to connecting experts from different parts of the world with a larger community. With that, I can take questions. Thank you very much.
Thank you, Dr. Thota. We have some questions. The first is, could you speak again about what white blood count and bone marrow percentage is considered serious aplastic anemia?
So if your absolute neutrophil count is less than 200, it's called very severe aplastic anemia. If it is less than 500, it is called severe aplastic anemia. Your cellularity in your bone marrow has to be, so that's the absolute neutrophil count. It's not your whole white blood cell count. It's a part of your whole white blood cell count. And your platelet count usually is less than 20,000 or 20 in 10 to the power of the 9th in patients with severe aplastic anemia. Usually for a moderate aplastic anemia patient, it is greater than 200. If that's the number you're looking for, the 3-digit number would be greater than 220.
Thank you. Once a patient has completed ATG and cyclosporine and their counts were normal, but they've now start to see a decrease, would this be considered that the patient is now going back to moderate aplastic anemia, or they're just experiencing a relapse?
That's a great question. Thank you for asking that question. So when somebody is diagnosed with any degree of aplastic anemia, severe usually, or moderate, and required ATG and cyclosporine, how I tend to treat these patients once they have achieved remission, their best response, which I hope is a complete response, and have maintained that response for at least 1 or 2 months, I do not just stop the medication, I taper immunosuppression, because some percentage of people to maintain that response will need small doses of immune suppression. So it is entirely possible you could be one of those people needing very small amounts of immune suppression. So there is no going back to from severe back to moderate. It's technically called a relapse at that point. When we start noticing on your surveillance that your blood counts are going lower, depending on if it is extremely low, one could challenge with, again, if you had horse ATG before, go back to rabbit. Technically, it's a sign of relapse, or you are one of those people who just need small doses of immunosuppression to maintain your blood counts in a very good range.
Thank you.
Hope that answered your question.
Yes, thank you. Do you have any knowledge of any particular diets that are helpful for patients, or any good quality natural supplements for patients?
That's another amazing question. I think some of the lifestyle habits are important to stay healthy, not just for like bone marrow failure conditions and in general for health. I think the general quote is well-balanced diets, restricting your red meats, antioxidants are good for immune system. So we all want to do the best we could to stay healthy. Exercise is one of those things that have, and so if you're diagnosed with aplastic anemia and you worry about a malignancy in your future, in specific referring to MDS or AML, we all know exercise is a good thing, and fatigue is something that comes out of having aplastic anemia diagnosis itself. So I would recommend exercising per American Heart Association guidelines, 30 minutes 5 times a day, if that's not possible. To some degree, in terms of diet, healthy balanced diet, restricting to a minimal quantity of your red meats are some things I tend to follow. There are no general agreed upon guidelines for this thing, and antioxidants are always good.
Thank you. Have you seen megakaryocytic hypoplasia with moderate aplastic anemia, or is this associated with another bone marrow failure problem?
I'm sorry, I did not understand. Were you referring to megakaryocytic hypoplasia, which is decrease,
yes,
or hyperplasia?
Yes. Yep.
So there is
Hypo.
Decrease in megakaryocytic lineage. So there is a specific term. So in general, for moderate aplastic anemia patients, there is overall decrease in all 3 cell lineages, not specifically megakaryocytic lineage, but there are occasional cases, especially in that phase 2 trial that I have shown, of using Eltrombopag prospectively in the 42 patients. It does show that a small percentage of them have unilineage cytopenias. Most of them tended to be pure red cell aplasias, but there are certain patients where their megakaryocytic lineage was specifically depressed. Though that doesn't give you a diagnosis of aplastic anemia, it gives you an aplastic anemia-like process, an immune suppression, a stem cell that specifically hits your megakaryocytic lineage. So it's extremely rare, but it is possible. Yes, thank you.
Thank you. What percentage of thyroid disease is associated with immunosuppressive therapy?
Thyroid disease you're
Yes.
talking about?
Yes.
Hypothyroidism, developing hypothyroidism. So if that is the question, it is a extremely rare complications. The 86 patients that I have taken care of, that I've presented to you the data on, and the few patients that have managed over years, I have them go back to their general practitioners to watch their thyroid vitamin D levels, but it is not a common complication, especially in the patients that I take care of.
Thank you. Is there a particular criteria that is used to determine whether someone should go to a bone marrow transplant? This is coming from a patient who has bone marrow cellularity below 20%, a white blood count below 3.0. However, they have a good platelet and red cell count.
And I'm sorry, what did you say the age was?
No age. No age was mentioned.
So really that is, for me, it is an age-dependent process. If you're a 20-year-old or a 30-year-old, I would strongly encourage you, and depending on your donor search, not the degree of cytopenias, a diagnosis of aplastic anemia, whether severe or moderate. Your condition appears to be moderate. It is really an age-dependent process. Anybody, especially above and 50 and above, I treat them more with immunosuppression than with a bone marrow transplant, as the toxicities from the transplant approach itself is higher in that age group, and the long-term risk of acute leukemia and other things happening is 10% or lower. So it is an age-dependent phenomenon rather than a count-dependent phenomenon.
Thank you. This question is, if bone marrow biopsies are not always accurate, how much value should we give them?
It's a very important question. Bone marrow biopsies are accurate when they're done well. So sometimes you do get a report where they're giving you a diagnosis, but if you look at the finer print of this long report, there is a section where in their microscopic comments, they will mention optimal specimen or not so optimal specimen. So that is what I want you guys to pay attention to, not just the final diagnosis section, but when they read how long does the aspirate look spicular, we call it. That means there's adequate bone spicules on the specimen they're looking at. So it looks like it did come from the bone, not really peripheral blood that was pulled at the site that you got poked for your bone marrow biopsy. And how long was your biopsy? What did they say? The pathologist called it an optimal specimen. Sometimes if it's a difficult body habitus and you've tried 2 attempts, pathologist forces themselves to give you a diagnosis. My advice to you is always pay attention to the finer details. The bone marrow is the gold standard to diagnose your condition. Just make sure they're an appropriate specimen.
Thank you. What is considered a partial response to treatment?
Not normalization of your counts. So if your platelets have not reached a triple-digit number, your hemoglobin has not normalized, which is about 12.5 grams per deciliter for women, and you don't have a normal count, that is a partial response. So you need to have normal blood counts, which is considered a complete remission. So it is really defined by your blood counts a year into treatment or at least by 6 months into treatment.
Thank you. Our next question is, how long is it safe to be treated with cyclosporine?
I have had, that's a great question. I'm not sure if I know. So, the longer you are on immunosuppressive treatments, there are secondary things that could happen from it, like somebody who's been, for an example, bone marrow transplant patient who's been on cyclosporine for a long time, they could have impact on their kidneys, secondary skin cancers. But, you know, patients with heart transplant and lung transplant, they remain on immunosuppression. For some people, it's the rest of their life. So for like decades, they stay on it. So it is a medication that can be taken for a longer duration if you need it. I tend to taper off immunosuppression if you achieve a good response on my patient and watch your counts closely to make sure that you're not relapsing again. So it is a medication for other conditions people do take for decades, which is not common in aplastic anemia patients.
Thank you. Is it possible to treat moderate aplastic anemia to prevent it from becoming severe aplastic anemia?
So the treatment indications for moderate aplastic anemia, so treatment, so for some people, it does, whether you, it may be that you actually have severe aplastic anemia, you will have, and we've caught you early on in time. So even if you're diagnosed with moderate aplastic anemia and you're being observed for blood counts, if your counts are sliding down and there's a trend, numbers could fluctuate, but if there's a real trend that your counts have been worsening, like the third case I've presented in today's presentation, immunosuppression is the only way that your counts can be made better. If you're one of those people who are completely asymptomatic and you have very mild thrombocytopenia or very mild neutropenia, initiating immunosuppression in you will not change the, like I said, in 2/3 of the people, it's just a distinct process that does not progress. So it's really each case specific, and if your counts are okay, immunosuppression doesn't really prevent that AML from happening or that severe aplastic anemia from coming. So it's all defined by the trend of your counts. Hope that answers your question.
Yes. Well, thank you so much, Dr. Thota, for your time today, your presentation, sharing your expertise with all of us, and answering everyone's questions. If you would like to watch this webinar again at a later time, it will be available on our website within 2 to 3 business days. If we were not able to answer your question, or you have a question after the presentation, please send it to us at any time in 3 ways. You can send an email to help@aamds.org, call our helpline at 800-747-2820, extension 2, or submit a question on our Facebook page. On behalf of the Aplastic Anemia and MDS International Foundation, thank you for joining us today and making us your resource of choice for bone marrow failure information. The Aplastic Anemia and MDS International Foundation Medical Advisory Board and team are here to help you and your family, as we have done for the past 36 years. This concludes today's program. Thank you, Dr. Thota.
Thank you.